Now we get into an area that's become sort of more controversial lately, and some people think it's a new approach to do the surgery first before you do the orthodontics. But we actually published this particular option of doing surgery first back in 1978. So all this surgery first is nothing new. We incorporated this years and years and years ago and still use it, this basic approach today. Because many times you can do the surgery first, and I have some specific criteria when that can be done. But again, published back in 1978, doing surgery first before orthodontics. So these are the indications. Of course, if you have a class 1 occlusion with normal overbite and overjet, that can be achieved. In other words, your teeth are lined up such that you can place them into a class 1 occlusion with a normal, overbite overjet relationship without orthodontics, being done beforehand. That works out great. If you just need transverse discrepancies corrected, and that's all you need, and they can be eliminated and stabilized, hey, you can do it before the orthodontics. And if you position the teeth in such a way that the post-surgical orthodontics then will be predictable and stable, and post-surgical orthodontics will not create a malocclusion or worsening facial aesthetics. Some cases I've seen where this has been surgery done first, there's no way that they can get a really nice occlusal outcome without changing the facial aesthetics afterwards. You have to have adequate room between roots for interdental osteotomies if you're doing a multiple piece maxilla as surgery first indication. Risks, requirement for unstable orthodontics can be a risk as relative to stability of outcome if there's an increased post-surgical orthodontic time. And some of the studies show that the amount of post-surgical orthodontic time is significantly increased by doing the orthodontics second, doing the surgery first. And it can be extended considerably. So the choice of doing surgery first, you got to look at it. Sometimes it's easier to do some preliminary orthodontics beforehand, do the surgery, and post-surgical orthodontics usually, at least in my practice, usually doesn't take much more than 4 or 6 months post-surgery. Whereas if you have to do a lot of post-surgical orthodontics to finalize occlusion, you may be working for months and months, years maybe, to achieve an occlusion, and still you may have some difficulties with stability. You could end up with compromised functional aesthetic outcomes. And this is a risk when surgeons and orthodontists want to be part of the new trend. That can sometimes get you into trouble, not you so much, but the patient, when it may not be in the best interest of the patient to do surgery first, just so you can be involved with the new trend. So contraindications for doing surgery first: class 2 division 2 malocclusions. If you're unable to achieve a nice class 1 occlusion with normal overbite and overjet. Unstable orthodontics are going to be required to get the occlusion to try to come together. If there's major dental compensations requiring pre-surgical orthodontics to get the best outcome. Anterior open bite with accentuated caries of spee may be best treated with some orthodontics first to get segments lined up appropriately. If there's a significant tooth-size discrepancy requiring a pre-surgical correction, you may end up with a compromised outcome. If there's extensive crowding in the upper or lower arches, that may be a contraindication to doing the surgery first. And this just sort of goes on, I'm not going to go through all this, but these are additional reasons why there's a contraindication to doing the surgery first. So in your decision making, you want to make sure that any preliminary orthodontics will make the surgery easier and more predictable with higher quality outcomes. Where post-surgical orthodontics will be difficult and unstable, you've got to take that into consideration trying to do surgery first. Post-surgical orthodontics will cause vertical or AP changes in the skeletal and occlusal structures. that can be a very important aspect of the decision making. This is important. Probably the most important factor is put your patient first, not your ego, and not your sales pitch. Use common sense when determining whether to do surgery first or orthodontics beforehand. Now we'll get into the last section, and I think this is a very important section for orthodontists and for surgeons to understand, and that's occlusal plane alteration. We can surgically alter the occlusal plane angle, and this can change the functional and aesthetic outcomes of the jaw structures. The normal occlusal plane angle, which is a line described as going through the buccal tips of the first bicuspids through the proximal, the buccal groove of the second molars, that line compared to the Frankfurt horizontal plane. We're just going from infraorbitale to porion. That angle is normally about 8 degrees. If we're below that angle, approaching 0 degrees, then we have a low occlusal plane angle facial morphology. If we have a high occlusal plane angle going higher, 12 degrees or higher, then it's a high occlusal plane angle facial morphology. So who can benefit from alteration of the occlusal plane? Basically two types of patients. Brachiocephalic or low occlusal plane angle facial type, or the dolichocephalic or high occlusal plane angle facial morphology. So we'll look at the low occlusal plane angle patients first, and these are some of the aesthetic factors that we notice. They have that brachiocephalic, that real square, prominent jaw formation, prominent mandibular angles commonly. They may have hypertrophy of their masseter muscles, and they may have a decreased vertical height of the lower third part of the face. In profile, they may have maxillary AP hypoplasia and mandibular AP hypoplasia. They have that low occlusal plane angle facial morphology. And if it's a real severe case, they may have poor self-image of themselves. This young lady has a nice occlusion, but she did have 4 bicuspid extraction and retraction of the teeth to get them together because there was some pre-existing crowding. But it does sometimes worsen the aesthetics. For orthodontists, to be very careful about extracting bicuspid teeth because you may worsen the patient's aesthetics in the attempt to get the remaining teeth together. So patients with these brachiocephalic, these low occlusal plane angle facial morphologies may benefit by a clockwise rotation, where the posterior aspect of the maxilla and mandible are moved upwards and or anterior aspect of the maxilla and mandible moved downwards. Clockwise rotation of the maxillomandibular complex. Well, what effect does this have? If we do this clockwise rotation of the maxilla and mandible, there are certain things we have to understand will occur. The first thing is the maxillary incisor teeth. The axial inclination will decrease and become more vertical, the same amount that the occlusal plane changes. The lower incisors, it may be more vertical in orientation, pre-surgery. When you do this clockwise rotation, the lower incisors will increase in axial inclination, the same amount that the mandibular occlusal plane changes. At the base of the nose, if we fulcrum around the incisors here, as we increase the occlusal plane angle, the base of the nose here at the osteotomy site will come forward. But look at the chin. The chin that was out here, it will move posterior. Those factors are all affected by the clockwise rotation of the maxillomandibular complex. So for this lady, we're going to advance her forward here at the incisors, 7 millimeters. We're going to do this clockwise rotation, moving the posterior maxilla and mandible up this way. So at the base of the nose, we're going to come forward 8 millimeters, but the chin's going to go back. The chin is going to come forward some for this girl, but not nearly as far as the maxilla because of this clockwise rotation. Now, when you do these clockwise rotations, if you're doing a sagittal split on the medial side, here, you're going to have to remove some bone, or you're going to have bony interferences. So this, simply all we did was do a clockwise rotation of the maxilla and mandible. We're able to get this for this young lady. That's all we did. We did nothing else. See the improvement in her profile, how her lips have been filled out here. Again, because we rotated this up this way, we brought this forward. Look at the improvement in her nose, and that's because the bone at the base of the nose here came further forward. We didn't do anything to her nose. But her nose looks much more attractive, much more in balance. You don't see the little bump here anymore because the nasal tip came forward here slightly. And a good stable occlusion. So the benefits of this clockwise rotation is that we normalize occlusion, we improve facial balance, we can decrease the chin prominence just by that rotation, we increase the mandibular plane angle, can improve the smiles, and importantly, improve the patient's self-image. A negative impact that can occur is with that clockwise rotation, since the mandible in some cases may move backwards, is that you could decrease the oropharyngeal airway. So you got to look at that. You got to look at your airway beforehand to make sure that you can accommodate that kind of movement. Another patient, a little bit more severe, class 2, division 2, malocclusion. You can see how sunken in maxillomandible are. Cephalmetric analysis is her upper incisors are actually angled backwards. Her lower incisors are angled backwards as well. She's congenitally missing 3 bicuspids. This is her initial occlusion, class 2, division 2, missing a bicuspid here, bicuspid there, and bicuspid up here as well, and here. So I had the orthodontist just align level the arches. She has a tooth size discrepancy, so I had a space opened up here to accommodate that so that later this lateral incisor can be built up to a normal size. Reopened up the bicuspid spaces in all the quadrants where they were missing. So here she is pre-surgery, got the upper incisors back out into a normal inclination as the lower incisors, but she's a low occlusal plane angle. Remember, the normal occlusal plane angle is 8 degrees, so we created an 8-degree occlusal plane angle. We did a 3-piece maxilla, advanced it forward, downgrafted it some, moved it up in the back. Lower jaw, we did bilateral sagittal splits, we did bilateral body osteotomies, and a genioplasty. So we cut the mandible into 1, 2, 3, 4, 5, 6 pieces. Put it all back together. Enabled us to end up with this kind of result. Notice the spacing maintained here between around the lateral incisors, as those teeth are going to be built up to eliminate the spacing and to correct the two-size discrepancy. So here she is at her end result. Vertical height of the face much longer than it was before. Improvement in her facial profile. And a good stable occlusion. So let's look at the high occlusal plane angle facial type now. And some of the aesthetic factors we see here. They have this dolichocephalic appearance. narrow face. They may have lip incompetence. Excessive tooth-to-lip relationship is common in these people. Gummy smile oftentimes is seen in these people. They have a high, poorly defined mandibular plane angle. You see in profile, they have this high mandibular plane angle, high occlusal plane angle. And mandible usually quite retruded. Maxilla also usually retruded. Nose looks big because everything is retruded. It's more of an illusion sometimes. And these people oftentimes will carry themselves with their chin elevated upwards to make their chin look better, and importantly to open up the airway so they can breathe better. So this high occlusal plane angle facial morphology, this is cephalmetrically what we will see. We see this high occlusal plane angle. Remember, it should be about 8 degrees, a high mandibular plane angle. Maxilla and mandible retruded, as reflected in our numbers here. They can have anterior vertical maxillary excess, but definitely almost always have posterior vertical maxillary deficiency. The oropharyngeal airway back here normally is quite constricted in these people. The dimension between the posterior pharyngeal wall and soft palate, posterior pharyngeal wall and the base of the tongue should be 11 millimeters. See, she is 5 millimeters, so she has less than half the normal dimension that she should have back there. So many of these patients have severe sleep apnea, airway issues, they're mouth breathers. They also are the most common type to have nasal airway obstruction. So we have a decreased oropharyngeal airway, decreased nasopharyngeal airway, sometimes increased angulation of the lower incisors. Sometimes the maxillary incisors may have a decreased angulation. So these are things to look for. When you see this high occlusal plane angle facial morphology, obviously we have a dental facial deformity. But additionally, most common facial type to have hypertrophied turbinates, most common facial type to have nasal airway obstruction, most common facial type to have a decreased oropharyngeal airway and sleep apnea symptoms, and importantly, this is the most common facial type to have TMJ pathology. Most common type to have TMJ pathology. So when you see this facial type here, this high occlusal plane angle facial morphology, you have to think all the airway factors, but you also have to think TMJ. If you don't think TMJ and you just do orthognathic surgery on these cases, you're going to have a significant number of these cases relapse. So these people can benefit from a counterclockwise rotation, where we're going to come down in the back and up in the front if necessary, counterclockwise rotation to get the occlusal plane back to a relatively normal inclination. So when we do this, remember, when we do these counterclockwise rotations, the upper incisors, which may be vertical to begin with, they'll increase in angulation the same amount that the occlusal plane changes. The lower incisors, if they're overangulated to begin with, they'll become more vertical afterwards. They'll decrease in angulation the same amount that the occlusal plane changes. So knowing that will help you determine the pre-surgical orthodontics that are indicated. So for this young lady, counterclockwise rotation, down in the back, up in the front. So she's going to come up about 3 millimeters in the front, a little bit in the back, but mainly the lower jaw, because she had an open bite, it's going to rotate upwards and forwards here. We're also going to build the chin up a little bit, so her chin point's going to come forward a total of 18 millimeters in this single procedure. She also had displaced articular discs, so I addressed those. I fixed her joints. If I would not fix this lady's joints, she would have a predictable relapse. But I put her disc back in place, that stabilized her joints, so I could at the same time correct the jaw deformity. So this is what we're able to end up with for her. Improvement in her profile. And a good stable occlusion. If I would not have fixed her joints, you would not see this occlusion today because it would not be stable. Another young lady, you can see she's got a little vertical maxillary excess, retreated maxilla, retreated mandible, some sleep apnea issues, lip incompetence, occlusion. She's had a lot of dental work, but a class 1 custard molar relationship. She's got some TMJ pathology. Again, when you see these, high occlusal plane angle facial morphologies, you got to think TMJ pathology. You got to think nasal airway obstruction. You got to think oropharyngeal airway decrease and sleep apnea. So we're going to put her disc back in place, counterclockwise rotation. We did a little genioplasty here. So her chin point right here came forward 20 millimeters. Maxilla came forward 5 in the front, moved up 5 in the front, moved down in the back. So just that, that counterclockwise rotation. It allows us to get these kind of outcomes. So here you see her 6 months post-surgery. Here she is 9 months post-surgery. Able to maintain, very nice facial aesthetics, very stable, pain-free, because we address the joints, we fix the jaws. That counterclockwise rotation is stable if the joints are healthy or if you make the joints healthy with your surgical approach. Her occlusion, 9 years post-surgery. So this is, I think, one of the most important studies that has been done on my patients by 2 of my former fellows, João Concalves and Daniel Casano, where we looked at the stability of counterclockwise rotation of the maxillomandibular complex when it's advanced, and the influence of the articular disc in our outcomes. So 72 patients in the study. We divided them into 3 groups. Group 1 had healthy TMJs, and I just did the orthognathic surgery only. Group 2 had displaced articular discs. I put the disc back in place with the MyTech anchor technique and did the orthognathic surgery. Group 3 had displaced discs. I just did the orthognathic surgery only. I did not fix the joints. All 3 groups had, pretty close to the same amount of advancement, roughly around 13 millimeters of mandibular advancement measured at menton. So pretty well matched groups. Counterclockwise rotation pretty much matched relative to change in the occlusal planes. So, this is just depicting what things were like beforehand. Group 1, we put the disc back in. The disc was already in position. I just did a double jaw orthognathic surgery. Menton came forward about 12.5 millimeters. And measuring at menton, the amount of relapse was 5% of the amount of advancement, or about 0.5 millimeter for every 10 millimeters of advancement. That's pretty darn stable. I will accept that. Let's look at group 2. They had displaced discs. I put the disc back in position with this special MyTech anchor technique that we developed a number of years ago. Counterclockwise rotation forward. Menton advanced forward 13.5 millimeters. The relapse, 1%. That means 1/10 millimeter relapse for every 10 millimeters of advancement. Incredibly stable. Let's look at group 3. Had to displace discs, and I left them out of place. I did not put them back in place. Average advancement, 13.6 millimeters. The average relapse, 28%. Huge relapse, unacceptable relapse. Why? Because I did not fix the joints. Biggest factor that causes relapse is failure to diagnose and properly treat a pre-existing TMJ problem. What happens with this alteration of the occlusal plane relative to the airway? Well, we've done a number of studies on it that are all published. But what we found is if we advance the mandible forward, class 2 into a class 1 at the tongue base, we move forward about 76% of the amount of mandibular advancement for the first 10 millimeters. The soft palate will move forward because it follows the tongue. It'll move forward about 50% of the amount that the mandible is advanced. Now, if we set the mandible backwards, however, that's going to decrease the airway. So if you have a prognathic case and you're moving it backwards, the airway back here is going to decrease at the tongue base 65% of the amount that you set that mandible backwards. So when you're treating a prognathic patient, you better be sure that you have a better than normal airway present before you set that mandible back, or you could create a sleep apnea issue for the patient. The soft palate will move back about 50% the amount that the mandible is set back. So does orthognathic surgery cause or cure temporomandibular disorders? This is a systemic review, meta-analysis. There were 29 studies with 5,229 patients, but it combined them together. These studies combined class 2s and class 3s. And overall, the patients tended to improve in any pre-existing TMJ issues, but some patients remained with their pre-surgery symptoms. Some asymptomatic patients, particularly class 2 high occlusal plane angles, became symptomatic after surgery. And the high occlusal plane angle patients tended towards increased pain and condylar resorption post-surgery. We've been talking about that. Results overall were unpredictable as to who would develop condylar resorption and how they would be affected by pain. So it would be important to warn patients if they have pre-existing TMJ problems that orthognathic surgery may or may not improve pre-existing temporomandibular disorder symptoms. Now, the weaknesses of this particular study, all those studies together, was many of the studies combined class 2s and class 3s together. And we know class 3s have a lower occurrence of TMD cases. And in fact, one of our previously published studies, we had 42 class 3 patients, and the pain was essentially non-existent pre-surgery and in the longest follow-ups. There's virtually no pain in these people in class 3. So combining them with a class 2 really dilutes down the quality of the studies. And 10 of the 29 studies were questionnaires. They just sent out questionnaires to patients, did not clinically evaluate the patients. 6 studies had 6 months or less follow-up. And you're only halfway through the healing process at 6 months. Skeletal stability was evaluated only in 1 of the studies. So in other words, the outcomes of the studies relative to skeletal and occlusal stability was not evaluated in 28 of these studies. MRIs to evaluate disposition was only performed in 1 study. 28 studies had no documentation of the pre-existing TMJ pathologies. And none of the studies reported post-surgery orthodontics, splints, PT medications, etc., that may be involved. And so there may be an incredible amount of study bias in this whole overall study that we did. This is another one. Does temporomandibular joint pathology with or without surgical management affect the stability of counterclockwise rotation of the maxillomandibular complex in orthognathic surgery? And 12 studies, 245 patients. In this particular study, high occlusal planing angle, counterclockwise rotation. And counterclockwise rotations are stable procedures in the presence of healthy TMJs. When concomitant disc repositioning with Mitek anchors in orthognathic surgery is performed, or when concomitant TMJ total joint prostheses in orthognathic surgeries are performed together, these provide incredibly stable outcomes. Procedures are unstable if there's untreated TMJ disc displacement or pre-existing condylar resorption status or TMJ status not assessed. So the health of the TMJs, the presence of TMJ pathology is paramount to having good stable outcomes. 3 studies looked at comparing clockwise rotation to counterclockwise rotations, and these 3 studies show that counterclockwise rotations compared to clockwise rotations in the absence of TMJ pathology is skeletally stable relative to occlusal plane, horizontal vertical changes of the maxillomandible. Does estrogen help prevent condyle resorption? The answer is no. 33 studies looked at this, and there's no evidence found that estrogen deficiencies contribute to mandibular condyle resorption. Next, at our next meeting, we'll talk more about the causes of condyle resorption. So our treatment goals in correcting skeletal, dental, facial, TMJ, and airway problems is to optimize the function, aesthetic, and pain outcomes. So this is just an 18-year-old with juvenile idiopathic arthritis, onset at the age of 9 years, a significant skeletal and occlusal problems. He's been in orthodontic treatment for about 6 years. Typical case, high occlusal plane angle, decreased oropharyngeal airway, TMJ pathology. Remember, occlusal plane angle should be 8 degrees. Airway back here should be 11 millimeters. So she's treated with counterclockwise rotation with custom-fitted total joint prostheses. Occlusal plane returned to normal. Mandible brought forward 24 millimeters with the counterclockwise rotation. Maxilla moved around and stabilized with rigid fixation, bone grafting in the maxilla were indicated, and our outcome. These are highly predictable cases. All orthognathic cases are basically highly predictable if the joints are healthy or you make them healthy. So surgical alteration of the occlusal plane and management of the airway and TMJs can provide a significant change in the function, aesthetics, and pain associated with jaws and the facial structures. So our outcome goals are to establish good function and aesthetics, make patients happy with the aesthetic results and functional results, and eliminate pain and discomfort. And I think this is achievable for most patients. And I thank you very much. That's the end of my presentation. Let's see. Okay, the question, we have questions now. Question number 1, how much is the maximum change in the inclination of the occlusal plane that I make? What measurement in millimeters or degrees do you select to evaluate where to leave the occlusal plane? Perhaps do you use an aesthetic measurement? I use cephalometric analyses to determine, and my clinical evaluation. And basically what I do is I figure out how much of a deformity there is present clinically and cephalometrically. Perhaps in our next meeting I can explain that in a little bit more detail. The Frankfurt horizontal plane is not always accurate. The position of nasion is not always accurate, and so I oftentimes will adjust the AP position of nasion. I will adjust the vertical position of porion or infraorbitally until my cephalometric measurements for that patient correlate to my clinical impression. And if so, then I can use normal cephalometric parameters to reposition the maxilla in the mandible. So I'm basically trying to put the occlusal plane relative to Frankfurt horizontal down into about an 8-degree inclination for females, for males, and maybe about 10-degree inclination for females. Let's see. At what age for male and female is recommended to make surgical assisted rapid palatal expansion? Well, you know, I don't do that technique. I don't do surgical assisted rapid palatal expansion. But I would say, obviously, if you do it at a younger age, you're going to get a more predictable expansion of the palatal suture. When patients may get into their later teens and older, that suture may fuse, making it more difficult, to get expansion. Obviously, if you did a SARPI technique, you could do that, essentially at any age. To assist you in getting it. But if you do the SARPI, you may also need to do a mid-palatal osteotomy so that you, in an older patient, so that you can get expansion there and not just push the teeth out through the alveolar bone. Okay, any other questions? I only see these two. Are there any others? We'll wait a few minutes and see if anyone else has any questions. No more questions now. Okay. So what I plan to do is at our next meeting, it will be, I believe, November 8th at the same time. And at that presentation, I'm going to talk about TMJ problems. It's going to be all about TMJ and all the different common pathologies that we need to be aware of as clinicians, be us surgeons, orthodontists, dentists, plastic surgeons, craniofacial surgeons. We all need to understand the different TMJ pathologies because they're very, very common in all of our populations. And we need to be able to determine what conditions are present and be able to understand what protocols are available to treat those conditions in order for us to have stable and predictable outcomes. The meeting after that on November 10th will be in reference to sleep apnea and the various techniques and procedures for diagnosis and treatment of sleep apnea, particularly focused on upper airway restriction and how we can correct those particular areas. So, one more question, number 3. How often do you do total joint replacements with orthognathic surgery, and when is in 2 operations? For the total joint prostheses, I do all those almost always in a single operation. The system I use is a custom-made device, and again, next time we'll talk in detail about the total joint prostheses, how we do them, expected outcomes, all that stuff, all the techniques. And again, I just do it all in one operation. I do a lot of total joint prostheses. I probably do 50, 60 patients at least a year with total joint prostheses. Part of that is due to the fact that I've published so much in this area. I do a lot of it. There's not too many people that can do it really well in the United States here, all in one operation. But they're highly predictable treatment outcomes for patients. Understanding the pathologies for which total joint prostheses are indicated, is important. Being able to provide the surgical skills and the abilities to treat these patients can be so rewarding to patients. There's so much we can do to help these patients get out of pain, have stable outcomes, look normal again, function normally again, etc. Question 4, how would you predict autorotation of the mandible in STO? Let's see. For autorotation, that's pretty basic because I don't rarely do I just do auto rotation. I'm gonna to get the best outcomes, I'm gonna change the occlusal plane frequently, so I don't rely on auto rotation. Sometimes you can do it, but with auto rotation, basically what you're doing is, I guess you're doing the maxilla, moving it upwards, and allowing the mandible to rotate upwards and forwards. So the way I would do that would be do a prediction tracing and trace out a mandible on a separate acetate paper. Superimpose that traced mandible on your original acetate paper, put a pencil in the contour head, and rotate the traced mandible upwards to the height that you want it. Then you can see where your mandible is going to move to, and then you can put your maxilla into the proper position. That's hard to describe. That would be something that would be better to sometime do, maybe on a video presentation where I can show how I actually trace out prediction tracings, how I do cephalometric analyses, trace out prediction tracings, I do all that. And of course, now today we do a lot of that with virtual surgical planning. So even though I trace out my ceph to determine exactly how I want things done, we put the final structures into their final position on the 3D surgical model. Any more questions? Well, it's really been an honor for me to present to everybody today. I hope that this presentation was helpful to you in understanding some of the basic techniques for orthognathic surgery, getting a little teaser on the effects of the TMJ relative to stability and pain factors. And hopefully you will join us next time when we talk about more specifically the different types of TMJ pathologies and how they can be treated for highly predictable outcomes. Follow the next episode with sleep apnea and how we can treat these people to have really good quality outcomes for them as well. Any other questions or comments? Okay. Is that it then? Anything else, Valeria? Okay. Well, thank you so much. I enjoyed talking with you all.